Can you see the recording icon, guys?
392, 392 slides, sir. We have noticed.
Can you hear me? Can you hear me properly?
Yes, sir. Yes, sir. Crystal clear.
Okay, all right. And can you see the recording button? Is it on there?
Yes, it's on.
And you're seeing my my
Yes, sir.
first screen of slideshow?
Research
Yes.
methodology. Yes.
Yeah.
I
Okay.
mean-
All right. Okay. Fantastic. That's good. Okay. So yes, this is actually going to be over 2 sessions. So I'll do one half today, and the second half tomorrow, because this is a very, very important topic, and it needs to be covered, and we need to spend some time on it so that you guys genuinely understand what I'm saying today. Okay. All right. So good evening, ladies and gentlemen. Thank you once again for joining in for the session on research methodology, Thoracic Gurus Online. Today, I'm going to be talking about a topic which I think most of the surgeons are pretty weak. They don't seem to understand what exactly is needed to read a paper, what is the background of critical appraisal of a paper. So this is in 3 sections, this talk, actually 4 sections. The first section is to understand the concept of research methodology, to understand what is evidence-based medicine. Okay. The second section is to understand statistics. So we'll go through the basis of statistics, try to understand what is used, where it is used, and in which clinical scenario you use statistics. And the third one then is how to critically appraise a paper. And that we will do tomorrow, because I will present this talk and then I'll put it up on the YouTube channel. I suggest everybody to listen to the talk. I don't expect you to understand everything straight away. Or even if you understand, I don't expect you to retain everything straight away. So my suggestion is that you go back and revisit this talk. And then tomorrow we will do how to critically appraise paper. And I will throw, first we'll talk about how to appraise, and I'll go through some slides, and then I'll bring up some studies. And I will get you guys to see how much you have understood the concept of what I taught today. Okay. FEBTS or FECTS, the European board exam, you're given a paper in your hand, and you're given an hour, and then you have to come back and discuss the whole paper, having critically appraised it. So that is why I want to train you to know how to critically appraise a paper. But you cannot do that till you understand basic statistics or basic facts of research methodology. So today's lecture is all about basic facts. It's a very dry topic, but we'll try and liven it up a little bit so that you guys get interested. My suggestion is, no matter what it is, just hang in there. It's going to change your future understanding of evidence. Okay, it's very, very, very important. This is again a very important talk. Okay, so first and foremost, before I start, just to get a little bit of excitement in the room, can I get somebody, Vikas can come in or Shilpa can come in? Tell me
sorry
what is...
to interrupt you, sir. Sir, we can
Yeah.
see the presenters view, sir.
Oh, sorry. Good, you told me. Thanks for that. I'm going to take this away. Okay. That's why I was asking whether you could see. So now can you see the view?
Yes.
Yes.
All right.
Yes, sir.
So now I want somebody to come in and give me a definition of evidence-based medicine. Again, a very common question in the exam. Somebody just define, when I use the word evidence-based medicine, what do you mean by evidence-based medicine?
When we say,
yeah, who is going to take it? Vikas wants to take it. Okay, come in.
when we say it's an evidence-based medicine, that means we are trying to say that there is enough data. The treatment which we are going to give is supported by enough data regarding the safety and efficacy of that treatment. That means it has been proven by trials.
That's fine. That's fine. Just give me 2 lines of an answer. So Shilpa, you want to give me an answer?
Actually, it's well summarized. It is nothing but application of the knowledge into medicine, which is supported by enough data. I mean, I echo with what you said.
Okay, all right. So this is the definition.
Mhm.
Application of best evidence from best medical research to treat patients. Okay, please write this down because this is the standard. This definition comes from the original paper of evidence-based medicine. Okay, so there was in 1992 there was a evidence-based medicine working group who published the concept of evidence-based medicine. So please write down this in your book. Everybody sit with 200-page notebook. Today, you have to understand the concepts I'm going to tell you. So until and unless you write and draw, you will not, nothing will go into your head, okay? So please write down this definition. This is the original definition. This is the definition which I want you to tell. I don't want you to tell your interpretation. It's okay if you don't remember this to tell your interpretation, but this is from the original paper, okay? So application of best evidence from best medical research to treat patients. It's as simple as that, okay? All right. So how do we grade medical research? Let's look at that, okay? So there are three concepts of grading of medical research whenever we do that. One is grading of evidence. Second is the quality of the evidence. And the third is the strength of recommendation. Again, everything on the top is a question in the Viva, okay? And everything at the bottom, the blue bit is the answer, okay? This is quite, I'm giving it to you, I'm spoon feeding it to you, okay? But it's quite important to understand. So everything on the top comes in as a question. Even in your interview, I will ask you this question: how do you grade medical research? Okay. So remember, this is not just for the exam. This is also for interviews, for future fellowships, etc. So how do you grade medical evidence? Is first there is something called as grading of evidence. Second concept is the quality of evidence, and the third concept is the strength of recommendation. Okay, that's how you grade it. So the standard which everybody, all of us understand is like this: level 1, level 2, level 3, level 4, level 5, which starts with a meta-analysis and goes down to expert opinion right at the bottom. But this is not based on a paper. This is the paper that I want you to quote whenever you're talking about grading of evidence. Okay, so this is the paper I want you to quote. It's called as SIGN, SIGN, and it's called a Scottish Intercollegiate Guidelines Network. How guidelines should be worked on. Okay, so there are two concepts to this which you have to understand. How SIGN works. There are two concepts. The first concept is it is talked about level 1, which is a meta-analysis on an RCT. Level 2 is systematic review of case control or cohort studies. Level 3 is non-analytical studies, which is case reports and case series. And level 4 is expert opinion. Okay, so guidelines are based on this concept. So these are 1, 2, 3, and 4. Okay, and then in addition to this concept, what the SIGN did was it added some pluses to each of these numbers. So if you had a 2+, then it is a high quality evidence with very low risk of bias. If you have a 1+, then it is a well conducted with low risk of bias. The first one was very low risk of bias. The second one is low risk of bias. And then if you had a minus sign in front of the number, then there is a high risk of bias. Okay. So when you put the first slide and this slide together, you get this graph. Okay. So this is how the graph is constructed. This is how the table is constructed. That 1, 2, 3, and 4, but the plus 2+, 1+, 1 minus, 2+, 1+, 1 minus. For level 2 recommendation, for level 2 evidence, in addition to level of bias, they have also spoken about relationship being causal, which means A causes B. Okay. So they have spoken about a high probability of the relationship being causal. The 2+ is a moderate probability of relationship being causal. So the bias is still there, but they're talking about causal relationship. So a moderate probability of the relationship being causal. And the third one is a risk that the relationship is not causal. That means A is not causing B. Did you understand this? You have to keep giving me feedback on this one. This talk
Yes, sir.
cannot progress
Yes.
until and
Yes, sir.
unless
So
you give me
what does
feedback.
causal
Repeat the same.
relationship mean?
Causal means A causes B.
B.
So yeah,
Understood.
you eat sugar, your blood sugar goes up. Okay, so A causes B. High diet content of glucose, and if you look at blood sugar levels, high diet content causes high blood sugar level. Okay, so that's called as causal. So
How
that's a
about the
causal
minuses,
relationship.
sir?
Yeah. Sorry,
Sir,
what
is
about
it
that?
same as a confound?
Okay, let me go back.
Sir, is
Okay.
it same as a confound?
Okay. So let me go back. These four things you have understood. The next thing is 2+ for high quality with low risk of bias. The second one is well conducted with low risk of bias. And the third one is minus, in which there is high risk of bias. Okay. So this whole thing is put together. But in the second part of this level 2, they have included the relationship is causal. Okay. So there is a high probability if the relationship is causal in the study, it gets a 2+. If it has a moderate probability that the relationship is causal, it's get just 1+. And if there is a risk that relationship is not causal in that study, then it gets a minus. Okay, it's very simple. A lot of concepts will become clear if you keep reviewing my slide again and again. Okay, but we got to progress ahead, otherwise we'll get stuck on every slide. Okay, now grade. Anybody has heard of the word grade? What do you mean by grade of recommendation? Anybody can come. Bhushan can come in and tell me what is grade of recommendation. Bhushan, are you there?
Grade, yes.
Yeah. Have you heard of the word grade?
Grade of
Grades of recommendation? No. Okay.
Yes,
All right.
grade A, grade
B. Okay. So
B
what is the word
recommendation.
grade stand for in the grade of recommendations? Do you know that it is actually an acronym? So
Yeah,
grade of recommendation stands for grade of recommendation, assessment, development, and evaluation. Is GRADE. Okay. This is the complete form of grade. So grade of recommendation, assessment, development, and evaluation. So whenever we talk of grade, there's this system of recommendation called a GRADE. Okay. So on grade of recommendation, you have A, B, C, and D, which could be highly recommended, favorable, not so favorable, and not recommended. Okay. So there are many ways that grade can come through. Whenever you read a paper, you have to look at the grade of recommendation that that paper has used. The commonest one is the one which is in sync with the Scottish guidelines is A, B, C, and I. Okay, where recommended, good, strong evidence, fair evidence, but the I is for insufficient evidence. Okay. So whenever you read a paper just like this, if you're reading these guidelines, revised ESTS guidelines for mediastinal lymph node staging, look at there, the level of evidence is mentioned in the paper. What have they used? Whatever one that, there are many types of evidences. Okay, so whatever one they've used, it will be mentioned, and whatever is the grade of recommendation will be mentioned. So A, B, C, D, E, or A, B, C, I, or A, B, C, D. Okay, there are many different types. So each paper uses one particular type. You need to know one type. When you talk in an exam, you just tell me one type. Okay, and the A, B, C, D, E, which is there, is for strong evidence, moderate evidence, insufficient evidence, moderate evidence against efficacy, and strong evidence against efficacy. Okay, so this is another method of doing grading. So you must know, at least this one is a good one to know, A, B, C, D, E. So strong evidence for treatment, moderate evidence for treatment, insufficient evidence for treatment, moderate evidence against treatment, and strong evidence against treatment. Okay, so these are the two types I want to. So sign is a very standard one, and then this grading of recommendation is a very standard one. If you know these two, you're quite all right. You may not know the variations, that's okay. Now, if you look at this other paper, which is the ERAS paper from the society website, they have used a completely different grade of recommendation. Okay, they have looked at the level of evidence here, but their grading of recommendation is strong and weak. So I want you to be aware that there are different levels of recommendation available out there. If you know the A, B, C, D, E, which this paper has used, that's a good one. This you can answer very well in the exam. So strong evidence for efficacy, moderate evidence for efficacy, insufficient evidence for efficacy, And then you're talking against efficacy. So moderate evidence for efficacy and strong evidence against efficacy. Okay. So this is a good one to know. And sign is a good one to know. So know sign and know this one, and you should be quite good in the exams. But whenever you read a paper, you must look at what is the grade system for that paper and what is the evidence, quality of evidence for that paper. Is it okay? Everybody with me? Still with me?
Yes.
Yes, sir.
Yes, sir.
Yeah. Don't ask too many questions at this stage. A lot of this stuff will not become clear till you go back and read it yourself. Okay. But just as long as you understand the concept, I'm trying to lay out the grounds for you to understand what is going to come next. Okay. All right. Okay. So we said that the third thing is quality of evidence. So how do you define the quality of evidence? Okay. The quality of evidence is defined on hierarchy of the study design, the study quality, and I'll address each one of these individually. The consistency of the study, the directness of the study, which means how well can it be correlated with clinical practice, and the level of recommendation. Okay. Is this clear? This is how, when I ask you a question, what do you mean by, how do you define quality of evidence that you're reading in a journal? This is the answer that you have to give me. Okay, hierarchy of study design, the study quality, consistency, directness of the study, and the recommendation of the study. Okay, now let's go to the next one. What about hierarchy of design? What do you mean by that? Hierarchy of design means meta-analysis is the highest hierarchy. Then comes the RCTs, randomized controlled trials. Then come non-randomized controlled trial. Then comes observational study and case reports. And last comes expert opinion or peer opinion. Many times in an exam I've asked, it's a very simple question. Could you define to me what is a hierarchy of design? And unfortunately, you don't even understand the question. That's the problem. But the language which I've used in these slides are all language which you will come across when you're reading a paper or when you're studying, looking at quality of evidence. Okay. So you must know this language. It's very important. It's a completely different language from what you use in everyday practice. So please remember these words. I'm flashing it in front of your eyes so that you become familiar with these words. And then we will talk about each one in more detail. So this is how research methodology is. There's a flow chart here, how to design a clinical trial. So you assign an intervention, decide whether it's an experimental or it's a observational. Okay. So if it's, if the intervention is assigned, it is, if the answer is yes, it becomes an experimental study. Then if you've used randomization, then it becomes a randomized controlled trial. If you've not used randomization, then it becomes a non-randomized controlled trial. If you haven't assigned an intervention and you're just looking at data, then it becomes an observational study. In data, are you doing a comparison of groups or not? If you're not doing a comparison, it's called as a descriptive study. If you're doing a comparison, then it's called as an analytical study. Okay. And then you look at the direction of exposure. So if the exposure causes the outcome, it's called as a cohort study. If the outcome is looked at and then exposure is analyzed, then it's called as a case control study. And if both are looked at the same time, it's called as a cross-sectional study. Okay, this graph is very important. So if the study is looking at exposure and then trying to decide what was the outcome, then it's a cohort study. If the study is looking at outcome and then deciding to find out what was the exposure causing the study, causing the outcome, then it's a case control study. And if it's both are looked at the same time, it's called as a cross-sectional study. Is this clear to everybody? Again, the language is completely different, so don't worry about it.
Yes, sir.
You will not understand at the first go. You will not understand at the first go, but it's okay. As long as you're getting familiar with the language I'm going to use, then I'm okay with that. So let's look at meta-analysis. Analysis of many RCTs. Okay, so you put hundreds of RCTs in, and then you analyze the data, and then you come out with what is there. So you pool the literature. All of them are looking at the same problem. Okay, very simple words I've used to explain to you what is meta-analysis. The advantage of meta-analysis is if you've got a rare disease or if you haven't got enough sample size, then you look at all studies, and so your sample size increases, okay? Because the quality of your recommendation or quality of finding depends upon the size, sample size. Larger the sample size, more chances of you being able to show that there is a clinical difference or a statistical difference. So meta-analysis allows you to pool all data into one, and then you look at the results. So statistical significance of results can be achieved. So in many multiple studies may not have got statistical significance because their number, sample size was small. But when you pool everything together and you do what is called as a meta-analysis, then your sample size increases. So there is more chance that you will get a statistical significance of result, okay? And the problem is the statistics can be fudged, okay? Because there are a lot of problems with meta-analysis, and I'll talk about that later when I talk about studies, that people will selectively pick up one study over another. They will start with 2000 study and eventually they will publish a paper on the basis of 5 studies and call it a meta-analysis. So a lot of statistics can be fudged in a meta-analysis. So when you read studies and you think that meta-analysis is the holy grail, be very careful. You have to look at the paper and critically appraise it to understand whether it is a good paper or a bad paper. Okay, meta-analysis can also be fudged. A lot of Chinese studies have done that, where they have just sat down with the SEER data and tried to squeeze as much data out and then put it together and then made a paper out of it. Usually editors are more sympathetic to meta-analysis, so they will, it's more likely that a meta-analysis gets published, but it doesn't mean that all meta-analyses are good. So I'll teach you that when we talk about how to appraise a paper, okay? How to look at it. The second level is non-randomized studies. We spoke about that. We spoke about cohort studies, which can be longitudinal. So they analyze a risk factor, okay? So A looking at B. And then case control studies, which are observational studies, okay? Just stay with these words. Don't get too hooked onto them, but become familiar with these words, okay? All right. Then the problems with randomized studies, as we've said previously as well, is that they can be very expensive. So to run a randomized control trial, you need a large number of patients, a lot of blinding has to be done. The investigator could be blinded, the patient could be blinded. And so there is a problem when you do randomized studies in terms of costs and time. They are very, very expensive. So there is a new concept which they use to do randomized studies. They're not as good as RCTs, but they save you cost and they save you time. And I threw this up in this forum so that if ever somebody asks you what's a probe study, you must know what it is. It's like a randomized study, but without the blinding. Okay, so you don't blind the patient and you don't blind the clinician, and that way you cut the cost dramatically. So probe means prospective, randomized, open label. The word is open label. So you also know what is you're doing. The patient also knows. So patient doesn't need to be in the hospital for the randomization and etc. and to give it secretly. The patient can go home. So it's like using an antihypertensive in one group to reduce blood pressure and using placebo in another group to reduce blood pressure. Both the groups know what they are getting, but we want to see what is the blood pressure effect on the patient. So that's a different way. The outcome is blinded. So they don't know, the groups don't know what is the end point that is being studied. So this is a cheaper way of doing an RCT, but not as good as an RCT. So some papers, if you read, you will see the word probe being used, that this was a prospective randomized open labeled study. And that is not the same as an RCT. It is, the blinding is not there in these studies, okay? All right. So far, so good. Everybody with me?
Right. Yes.
Yes.
Okay.
Yes.
So let's look at the other factor, which we said, study design. Okay. Study design also is very important when you're looking at quality of a study. So you have to look for presence of randomization. Okay. That we have all understood, that randomization is important. You're randomized to this one, this group or that group. Then you've got to look on whether the interpreter is blinded. It's quite important when you're interpreting a study. Quality is better when the blinding is there. Then you got to look at bias of the study. You got to look at whether appropriate statistics was used or not used. And that's why you have to understand statistics. You have to look at whether the conclusion that the study came in is actually supported by other studies in the literature. Okay, so it's very important that it is a supported conclusion. It's not something crazy. Then you've got to look at the quality of the journal in which this study was published. Okay, because impact factor matters. And if you're published in a good journal, there is chance that your study is of good quality, because they will not accept something. The rigor of selecting a study is higher in journals with higher impact factor. Okay, and whether the study was peer reviewed or not. Okay, so invited commentaries are usually not peer reviewed. Special editions are usually not peer reviewed. Those are usually just expert opinions. Whereas a RCT or a published article is usually peer reviewed. So it's very important to see if a study has been peer reviewed before being published or not. Okay, all right. What about the consistency? So I gave you 5 or 6 points. So the next point in that quality of evidence is consistency. So you have to look at number of published studies who are looking at the same problem and how consistent is this result across the studies. If it's a completely different result from what has been published so far, you got to worry about it. Whether did they do the study well, or is it genuinely a revolutionary study which is changing everything? Okay. The next point I told you was directness. So directness is how well can you put the result into patient outcome. Okay, that's quite important, because really what matters at the end of the day for us clinicians is how can it impact my clinical practice. So you need to know how well it impacts the patient outcome. So how does the intervention benefit patient? That's directness. That's what they mean by that. And then what are the recommendations with this? The recommendations have 4 levels. One is we should be using it. Second is we probably should be using it. The third is we probably should not be using it. And the fourth is we should not be using it. Okay, this is the 4 recommendations that can come out of a study. And depending upon how is the quality of the study, one of these recommendations will be done. Now, 1 and 4 are very easy to understand. Okay, they are very clear cut, easy for even a normal person to take it on board. So 1 and 4 are okay. It's only when you're dealing with 2 and 3, then you need to look at other help, because when the moment it comes probably, then you don't know whether you should use it or not use it. So then you look at guidelines. Okay, so then you look at the guideline, look at NICE guidelines, look at ESTS guidelines, and 2 and 3, some of the answers will be given by the guidelines. Okay, so that's how you interpret recommendations. So whenever as a clinician you see a study, you have to put it in one of these 4 groups. And then, 1 and 4, you start your clinic, change your clinical practice. 2 and 3, look at guidelines. Okay, make sure that whatever they're saying is actually factually recommended by your society. Okay, so what is the criticism of evidence-based medicine? Again, this is a question I often ask in the exam. Why do you think what is the problem with evidence-based medicine? There is a lot of publication bias. Okay, you may read a paper in the journal, but the problem is all journals may actually, they want to publish good positive papers. Research with negative results are usually not published by either the author or by the journal. So there is importance, very important to understand this, that all papers are not good enough to inculcate into evidence-based medicine. Okay, journals want new and positive findings. They don't want negative findings. Okay, only the good journals look at negative findings, and actually negative findings are very important. In research, very many times a negative finding can be, really dramatic, and that is also very important. So never get discouraged by negative results. More importantly, you must publish negative results. Okay, because negative results may actually change somebody's practice and may lead to a recommendation level 4, which is you should not be doing it. Okay, so don't worry about negative results. That's the point I'm trying to make. The other thing is evidence-based medicine cannot be applied to every clinical decision. Very often the experience of the person matters. You may not have guidelines which tell you what to do. Things like using empirical antituberculous therapy in a patient. There is actually no guideline to tell you whether you should or should not use empirical ATT in a patient with a cough. So sometimes evidence-based medicine can fall short there. So guidelines and recommendations also create what is called as a cookbook medicine. So we stop using our brains, we stop analyzing situations, and we put everything into the guidelines and say the guidelines said so, that's why I'm doing it. So we become dumber physicians if we follow the guidelines blindly. Okay, you have to have a rationale for following guidelines. And the way out of this situation is always multidisciplinary team meetings. So the best thing, if you are not sure about something, is put it up in the MDT, discuss the guidelines, and that way the cookbook medicine goes away, and more people will guide you on to what is the right way to do these things. And of course, individual clinical freedom and expertise may be suppressed. Some people may be very, very good at something, but the average Joe may not be good enough. So you can throw a guideline at him and say, but it is not recommended by this guideline. So individual clinical freedom and expertise can be suppressed if too much of evidence-based medicine is used. But my recommendation is evidence-based medicine is very good, and it's a good clinical practice, and it is a safe clinical practice. Both, one, it benefits the patient, and number two, medico-legally is very good, because in case you run into trouble, then you've always got the backing of evidence. And courts look very favorably on evidence-based medicine. Whenever you can produce a paper backing up your action, then you are in a better position in the court, okay? So two good examples of how evidence-based medicine dramatically changed clinical practice. One was the use of early thrombolysis therapy in ST elevation MI. It's a classic example. You must go back and read this paper, and it will tell you beautiful way how before this was not being done and after this suddenly started being done. And then the second one was use of ultrasound guided central venous cannulations. Both of these are beautiful examples of direct application of evidence-based medicine, which has changed clinical practice in patients. Okay, all right. So evidence-based medicine is gold standard. In my opinion, it is gold standard. I think RCTs are better than case series. There's no doubt about it. Meta-analysis can answer many questions, but be very wary of meta-analysis to make sure that they have not fudged the statistics, okay? So there is a way to know that, and I'll teach you when I talk about critical appraisal of a paper, how to make sure that it's a genuine meta-analysis. International and society guidelines can change practice. So very important to follow society guidelines or international guidelines. They will actually help you in many, many, many clinical conditions where you are getting into trouble. They will actually help you to, take you out of difficult clinical situations. But they are only guidelines. That's the other thing you got to remember. If you want to individualize a treatment to a patient which is not corresponding to the guideline, best is fall back on the MDT, okay? Go to the MDT, discuss in the MDT, and very often the MDT will back your decision. So you're allowed to make individual decisions, but get an MDT to back you, and that will make it safe for your clinical practice. A most important thing is audit your own practice. I mean, 99% of surgeons do not audit their practice in India. And in the Western world, in US and in the UK, 99% of people actually audit their practice, because in the UK, you have to submit your data to the society. If you don't submit your data to the society, you will not get appraisal and you will not get GMC revalidation. Same thing in the US as well. Almost most institutions submit their data to the society, and very quickly the society analyzes the data, and we can pick up outliers. We can pick up institutions which are outliers, or we can pick up surgeons which are outliers. In the US, some states do give individual data. In the UK, we give institutional data. But whatever you do, you audit your practice and look for improvements, because that is how your clinical practice will become better. And everything and anything that you do, the audit must be evidence-based. That is the key thing for a good clinical practice. Okay, all right. Everybody clear so far? Give me a feedback, please.
Yes, sir.
Yes, sir. Yes,
sir.
Yeah,
sir.
is it quite clear? These are
Yes, sir.
Yes,
important
sir.
flashcards. Every slide is like a flashcard. Okay.
Yes.
And so the question is on the top and the answer is at the bottom. So this is to just prime you into how to do research. Okay. So now we get into the nitty-gritty of statistics, and we'll try and understand all the studies that are there. Please sit with a pen and paper, and don't worry if you don't understand. That's okay. You can always go back and revisit. But the important thing is I'm putting it out there clearly for you, and write down your questions, and then not during the talk, but after the talk, or we'll do another session if you want, where we can answer specific questions about statistics. Okay. All right. So let's get on. So this is the best book I would recommend for all people. I personally have read this book over the years. Medical Statistics Made Easy. It's a BMJ publication. Excellent book, and most of my talk comes from this book. Okay. So it's a very, very nice book, very easy. If you want, I can share. I have a PDF of this book. It's very, very nice book. It's really the best book in statistics that I've read. And I've read quite a few because I have a postgraduate diploma in research methodology. So I did a 2 years university course in research methodology. So I've studied statistics in great detail. But after all that, after doing a 2 years postgraduate master's course, I realized that really the best book is this one, the simplest book. Okay. So let's look at statistics. So first and foremost, you need to understand softwares. Okay. So what are the softwares available out there? So SPSS. When I did my master's course in research methodology, I was using SPSS 11. And now it is SPSS 25. So a lot of things are changing, but it's a great software. SPSS is an acronym. It stands for Statistical Package for Social Sciences. That's the full form of SPSS. But it is one of the most frequently used software. The best way to do this, use this software, it's very expensive to buy as an individual, but it is very cheap to buy as an institution. So always the best way, if you want to use SPSS, is get admitted to any course in a university, and you can get the university license, and then you can use it. And that works out to be cheaper than buying SPSS yourself. Excel is actually a very good tool. Microsoft Excel, many people don't realize it, but Excel does have a lot of nitty-gritty within it for doing at least basic statistics. And if you want, someday I'll show you on an Excel sheet how to create graphs and how to create plots and how to do basic statistics. The other ones that are available, the software is SigmaPlot, Stata, Prism. Okay, so many are available. These are the ones which are used for medical statistics. There are lots which are used for non-medical statistics, but these are the ones which are used for analyzing medical statistics, because medical statistics is a bit different from normal use of statistics. Okay. So now there are, I want you to write this down. There are 7 types of statistics that you have to understand. Okay. The first one is statistics that describe data. Okay. So whatever data you've collected in your Excel sheet, there are certain words that we use which help you to describe data that you have entered into the sheet. And the statistics that describe data are percentages, mean, median, mode, and standard deviation. Okay. So I have categorized now everything into various packages, so you will understand it more easily. So the first is statistics that describe data. So percentage, mean, median, mode, standard deviation. That is statistics which describes data. The second statistics is which tests confidence of data. Okay. So there you have confidence levels, confidence intervals, and you have p-values. So it tells you that the probability of your data being correct is so and so. Okay. So it tests the probability of your data being correct. Anytime you start any study or anything, you always start with a null's hypothesis. And I'll come to null's hypothesis in a little more detail, but null's hypothesis states that there is no difference between group A and group B. Okay, that's the null's hypothesis. And when you do a study, what you're trying to do is you're trying to disprove null's hypothesis. You want to show that A causes B, or A is responsible for B, or A is better than B. So when you use statistics, you test the confidence of that answer. Whether are you really happy? Are you confident? What is the probability that your answer saying A is better than B is true? Which means how confident are you that you can disprove null's hypothesis? That is what it's meant by this slide, okay? And the other thing is confidence intervals are basically the ability of a statistical test to apply your result to the true population. So in a study, you take a sample population and you get a result. So how confident are you that that result, when it is recreated in the general population, it will be the same? That is called as confidence levels, okay? So I'll discuss each one of this in more detail, don't worry about it. So we spoke about statistics that describe data. The next thing we're looking at is statistics that test confidence. So confidence levels and p-values. The third thing is statistics that test differences between groups. These are called as parametric tests or non-parametric tests, okay? So very often people get confused, where is this parametric business coming? So these are tests which are used to look at differences between group A versus group B and tell you whether these differences are statistically significant or not. So this is where you use tests. You use parametric tests or you use non-parametric tests, okay? And I'll talk about this in more detail. So we have done 3 types of statistics so far. The fourth type of statistic is which compare risks. Risk of A versus risk of B, okay? And that in that you have risk ratio, you have odds ratio, you have risk reduction, and you have numbers needed to treat. And also there's something called as numbers needed to harm. So NNT, NNH, RROR is how you compare a risk of A versus B. Smoking causes lung cancer. What is the risk of smoking causing lung cancer? Then you will not use mean, median, and mode. You will use risk ratio. You will use an odds ratio, or you will use numbers needed to treat. You want to calculate how many people do I have to look at to prove that smoking causes lung cancer. You know, this is how you use statistics. Is it making sense what I'm saying so far?
Yes.
Yes, sir. Yes, sir.
Yeah?
Complete.
Okay. So that's the next group. Then after this comes another group where you want to analyze relationship. You want to know whether A is the cause of B, or if A changes, does B change? Did you understand that? So there you use what is called as correlation. So in correlation, you are correlating a rise in A. So we use the blood sugar sample. So, you know, does a rise in blood glucose raises HbA1c? That's a correlation. You understand? So correlation analyzes relationships. It tells you that if blood sugar rises, then HbA1c also rises. So that's a correlation between 2 variables, okay? And in correlation, it's only saying A causes B, but in regression, it actually gives you a value to it. What percentage of A rise will cause percentage of B rise? So regression is another technique that you use to analyze the relationship between 2 variables. Did you understand this?
Yes, sir.
Yes, sir.
Okay, all right. The next type of statistics is where you analyze survival, okay? So these statistics are used when you're talking about long-term outcomes in diseases. So whether surgery can improve survival in lung cancer. Okay, so this is the analysis. This is where you use a different type of statistics. So everything comes back to what is the question that you're asking. How to decide which one to use completely depends on what is the question that you're asking the statistical software. This is the key thing to understand. So if you do not ask a correct question, say you want to ask whether A is related to B, and you use a survival statistic test to answer that question, you will get a completely wrong answer. So that is why it's important. That's why I've categorized each one of this into various packages. So when you ask a certain question, you have to use a different set of statistics to analyze the outcome. So when you are analyzing survival, you're looking at life tables, you're looking at Kaplan-Meier plots, and you're looking at Cox regression. Now, Cox regression is a regression type of statistics which is specifically designed for survival analysis. I'll talk about each one of this in more detail. Don't worry about it, okay? So this is the next type of statistics that we spoke about. And then last but not the least, statistical tests which are used to analyze clinical investigations and screening. Is one investigation better than other? Is one lab better than the other? Is the result from one hospital better than another hospital? Clinical tests. In this, we are looking for the following factors. We're looking for sensitivity. We're looking for specificity. We're looking for predictive value. And we are looking for level of agreement and kappa. Okay. Don't worry about any of this if you don't understand it. We will discuss each one of them in more detail. But remember, whenever somebody says predictive value, your brain must say analyzing clinical investigation and screening. Whenever somebody says Cox regression, your brain must say, oh, survival. Whenever somebody says Kaplan-Meier, immediately your brain must say survival. You have to associate the top, the yellow thing with the blue thing. So that is why I'm flashing it in front of your eye. This is like a flashcard, okay? So this is the type of statistics. Is this clear now to everybody? Do you want me to quickly go through these before we go into more details?
Yes, sir.
Revision.
Okay, again,
Yes,
I'm going to flash this for you, okay? All right, go through this. Statistics that describe data are percentages, mean, median, mode, and standard deviation. So whenever somebody says the standard deviation of this study was, you must think describing data, is describing data. The mean age of this group was, you have to think is describing data. The next thing is statistics that are testing confidence of a group. So these are confidence levels and p-values. Okay, how confident are we that this represents the null hypothesis or does not represent the null hypothesis? The third one is what tests differences between groups. So this is parametric test or non-parametric test. So whenever I ask you a question in the exam, how do you test differences between two groups? The answer you have to say is, sir, I will use parametric test if it's normal distribution or non-parametric test in skewed distribution. I mean, we're talking in more detail later on, but just this is the answer that you have to give me when I ask the question at the top. The next one is, how do you compare risk between A and B? Risk ratio, odds ratio, risk reduction, numbers needed to treat, numbers needed to harm. They are both the same concept, okay? How do you analyze a relationship between A and B? If there are two factors, two constant variables, how do you analyze whether A is related to B? A difference in A makes a difference in B, correlation. And how do you specify that thing? Regression, okay? So this is how you analyze relationships. The next one is, how do you analyze survival? you do survival analysis, you do life tables, you do Kaplan-Meier plots, and you do Cox regression. Okay. All right. How do you analyze clinical investigations and screening? You look for sensitivity, you look for specificity, you look for predictive value, and you look for level of agreement and kappa. Okay, so far so good. Everybody's written this down.
Yes.
It's very
Yes, sir.
This will save you in the exam. I promise you this.
Mhm.
These 7 slides will save you. It will give you something to start talking about. Okay, even if you don't know the details of each one of these. Okay. Now, whenever we talk or whenever we do whatever else I'm going to do, there are some abbreviations which will come up. I'll just flash these for you. We won't go into details of each one of this at the moment. When we go into individual statistics, we will show these, okay? So ARR is absolute risk reduction, BMI is body mass, CI is confidence intervals, DF is degree of freedom, HR is hazard ratio, IQR is interquartile range, LR is likelihood ratio, NNH is numbers needed to harm, NNT is numbers needed to treat, NPV is negative predictive value, P is probability, PPV is positive predictive value, RRR is relative risk reduction, and SD is standard deviation. Whenever you read a paper, very often these are the short forms that are used, and you need to know what we're talking about, okay? All right, so now let's get into the nitty-gritty of each one of these studies. 1 minute. Okay, all right. So somebody don't write on the screen. Take it away, please. Whoever has just now scratched on the screen, take it away. Hello. I can't be disturbed because it will really upset the whole thing. Okay, I'm going to take it away because the rest of the talk is going to get disturbed. Okay. Okay, do not scratch on the screen, please, because it distracts me when I'm presenting. Okay, all right. So we are now coming to statistics that describe data. Okay, percentages, mean, median, mode, and standard deviation. We spoke about this. So let's go into individual details. Okay, so let's look at what is percentage. What do you understand when somebody uses percentage? The word percentage in statistics or in a paper. Okay. So percentages are mainly used in the tabulation of data. So when you're tabulating in a table, you might, instead of writing the actual data, you might use the word percentage, and you might actually put it, when you got multiple data, you put it as a percentage in the tabulation. Okay, so it gives the reader a scale to understand on which to assess or compare the data. Okay, so when you got many data in a table, when you put percentages, it gets you a feel of what is it in relation to the next data. You know, if A is more percentage and B is less percentage, so percentages give you a feel in the tabulation of data to understand how important is one data as opposed to the other data. Okay, so this is the understanding of percentage in statistics. So it's the number of items in a category divided by the total number in the group multiplied by 100. Okay, this is easy. Everybody can understand this. We do it every day in our life. But in statistics, it's in relation to a variable. We're talking about in relation to a variable. Okay, so this is how you will calculate percentage. So if this is a table of patients who are referred for heart transplant, so in the table, when you look at it, you might have 2 entries in various groups. Okay, if the groups are decided. So percentages give you an idea. When you just look at percentages, you get a flash of the idea as to what is the most commonest referral for heart transplant. So that is why percentages, if you look just at the frequency table, look at the frequency one, you do not get an idea of how common, which is more common referral. Okay, so just looking at frequency doesn't help you. So percentages actually give you a better understanding of the presence in a table. And that is why you use percentages. So in this, if you want to calculate what is the percentage of the group 30 to 39, then we know that N is equal to 80. Okay. N is usually the number of patients that you've looked at in a study. So we know N is equal to 80. So we know from this frequency that 14 patients got that. So 14 divided by 80 into 100, that is 17.5. That's how they got this 17.5. And this presentation makes you understand the how common is one group versus the other group, okay, in a flash. Whereas the frequency may not give you that idea. Okay. Another look. Sometimes you got to remember that authors use percentage to hide the number of variables or the number of patients. So whenever you're reading a paper, it is absolutely mandatory to know what is N. N is the total number of patients in that study. I'll tell you the number of times that I've read papers where authors have said 50% of the patients had benefit with this treatment. And then when you read underneath the percentage, you will find that there were only 4 patients in the study. Okay. And then 2 of them had benefit. And the author is reporting 50% had benefit. Hence, this treatment is better than that treatment. Do you understand? So it is very important to understand that percentage is the commonest thing that is used in papers by authors to manipulate data, to hide the true number in a data. Because really on 4 patients in a study, can you base your clinical decision? Would you actually change your clinical practice? But the problem is a lot of authors do this. And so be very, very careful when you are reporting percentage to in a paper. Never believe it, okay? Very, very important, okay. Clear about percentage? Does it make sense? It's a very easy concept, but it is important.
Yes, sir. Yes,
in
sir.
statistics, it's a bit different. That's why I'm trying to point out to you how you can use this. Okay. So next is mean. Let's look at mean. Okay. When is it used? It is used when the spread of data is fairly similar on each side of the midpoint, which is called as normal distribution. Okay. So when you have normal distribution, then mean is a good tool to use for representing your data. So it is the sum of observed values divided by the number of observation. Simple, very simple. Total everything up divided by the number of observed values will give you mean. So it's really arithmetic mean. You know, 2 plus 4 plus 6 plus 8 divided by 4. That's 4 times it. Or is the average. But it works only well when you have a normal distribution. So if you're looking at air leak, air leak post thoracic surgery, if all your patients had air leak for between 2 to 4 days, then it's very easy and very accurate to represent mean. The problem is if one patient out of that group had 18 days, then the mean goes for a toss, because that 18 days will complete, it's a skewed data, and that will completely destroy the mean. So then mean is not the correct representation in that group. Okay. So this is what they mean by it. That if you have a normal bell-shaped distribution, then mean is accurately represented. It genuinely means the average of that group. Okay. Is it clear? Clear? Yes or no?
Yes, sir.
Yes.
Okay. All right. So this is the key condition for mean. If you do not have normal distribution, you should not use mean. Okay. So look at this. 5 women in a study on lipid lowering ages are 52, 55, 56, 58, 59. So we add all of this together, which comes to 280. You divide the 280 by 5, that gets 56. So the mean is 56. Very easy. Okay. All right. It's good for normal distribution, but outliers are they completely screw the data. And I'll talk about it in a minute. I'll tell you. So skewed data is not good for mean. So then the mean is not representative. If in that group, the previous group, the sixth patient was 92 years, okay, then the mean became 62, which is not truly representative for that group, okay. So if the sixth patient was 92 and the mean became 62, if you look at the other 5, none of them are 62. So it has completely moved your mean by a skewed data, okay. So very important to understand that you should not use mean when the data is skewed, okay. So in a skewed data, you have to use median. Median more accurately represents the midpoint in a skewed data, okay. So let's come to median. Okay, clear?
Yes,
Median
sir.
is used to represent the average when the data is not symmetrical, okay. When you have skewed data, then median is okay to be used. So skewed distribution. Remember, whenever somebody asks you when should you use median, the answer should be to represent the average when the data is skewed. That is the answer. Okay, so what is median? Median is the middle observation. Okay, it's the middle observation when the observer values are ranked from the smallest to the largest. Okay, so you have to re-rank everything. You cannot use median if they are randomly arranged. So a statistical software will rearrange everything, A to Z or Z to A, and then the median can be calculated. Okay, if they are randomly arranged, it's almost impossible to calculate median. So you have to re-rank data from smallest to largest or largest to smallest. And then the middle observation represents median. Okay, so this is what we mean. So this is skewed data. This is not normal data. So in this skewed data, if you calculate it with your statistical software, the most middle data is this point. That is median. Okay, the point at which half the values lie above it and half the values lie below it. That's the other definition of median. So if you want to explain to me what is median, you can say in a skewed data, median is the point at which half the values lie above and half the values lie below it. Okay, did this make sense?
Yes, sir.
Yeah, okay. Is it okay to go at this level or do you want me to go at a higher level?
A little faster, sir.
Absolutely right, sir.
Absolutely right. Can go fast
This is
also.
okay.
Can go faster.
Yes, yes.
I can go faster because you know these points, but once I come to the further slides, you will struggle, I promise you. Okay.
Sir, we'll
So
go by the same speed,
that's
sir.
why go at
It
the
is
same
okay.
speed, it will
Same
always
speed.
Yes, sir.
This is
okay.
fine.
Once in a lifetime chance to learn everything all over again. Okay, next point. So median, so we have done this 5 patients, this thing. In this, if you calculate the median age, 56 is the median age, okay? 52, 55, 58, 59, okay? The same as the mean. Half the women are older, half are younger, okay? But if you add the 6th patient, 92, to this group, then what is the median? How do you calculate? It's very difficult to know the midpoint because there are 2 midpoints. There is 56 and 58. So the median in this group will be the middle of 56 and 58, that is 57. Did you understand that? So this
Yes,
is
sir.
better representative than a mean of 62. So this is the way you calculate median when there is no midpoint. You don't know what is the midpoint. So you calculate the 2 middles and calculate the middle of the middle. And that is the median in this group, 57 years. Okay. So the 57 better represents it than 62. Okay. So median may be used with interquartile range. You want me to go fast?
No, sir.
Yes, little faster,
No,
sir.
sir.
No.
This is the
very
question,
important.
basically. This, I don't think so anybody's going to understand this. What is IQR?
Okay.
No, same
So if
level.
you want
Same
to,
level.
I can go very fast with IQR.
No.
Okay. So the median may be given with an interquartile range. Okay. It's very important to understand interquartile range, which means that the value is divided into 4 quarters. The first quartile is a point where 1/4 of the values are below it. So when you got 100 values, if 75 is the point, then 25% are below it. So that is the first quartile. 0 to 100, 75 becomes the first quartile. So it starts at the far end of your graph. So first quartile means 1/4 values are below it. The third quartile is 3/4 values are below it. A lot of people, when I ask them first quartile, they say 25. 25 is not the first quartile. 75 is the first quartile. And third quartile is 25 because 3/4 of the values are below it. Okay, this is the way median is represented in statistics. And interquartile is the middle half. Okay, so interquartile range is the middle half where half the values are above, half the values are below it. So how does this get represented in statistics? So interquartile range is a measure of the spread given by the difference between the first quartile and the third quartile. Correct? So first quartile and third quartile. So between 75 and 25, if 100 is the number of values you've got, then between 75 and 25, whatever you've got, that is called as the interquartile range. Okay, very important to understand this. So it's a reverse of what you normally think. You think the first quartile is at 25, but the first quartile is at 75, at further end 75, and the third quartile is at 25 because 75% of values have to lie below it for it to be a third quartile. So the measure of the spread given by the difference between first quartile and third quartile is interquartile range between first quartile and third quartile. So I'll explain to you what it means. Okay, stay with me. So look at this energy intake over 24 hours of 50 patients. Okay, the median was 12.2 megajoules. All right, of this study. The interquartile range was 9.9 to 13.6. So the third quartile was 9.9 and the first quartile was 13.6. Did you understand this concept? The larger one is 25%. The lowest intake was 0. That means some patients were nil by mouth. Okay. And the highest was 16.7. So this is a study which has looked at it. Now, how can I represent this to the audience? That is the key thing. So we've got a median value. The statistics has calculated the interquartile value of third quartile and first quartile. The highest we know is 16.7. But how do I tell this information to the audience? You will not understand it. The moment I speak this, it makes no sense to you. Okay? So the way we represent this to the audience is by using a box and whisker plot. Okay, so the box and whisker plot looks at, this is a plot, this is the box and this is a whisker. Whisker means mustache. So you turn this around, it's like a mustache on the side. Okay, a long slimy mustache. So the third quartile is up here, the first quartile is up here. The box can be second or third quartile, it doesn't matter, and the median is in there. So this, the moment I put this out, I've got here 0 to 18 joules, the same data which I told you. We've made a graph out of this data and we have used the highest intake here. We've used the lowest intake. We didn't want to touch 0. So the two extreme values were deleted in the representation. So 4 point whatever was the lowest intake, 16.7 was the higher intake. And then we used a interquartile range to represent more than 50% fell within this group. And then we represented the median, which was whatever is the number here, 12.6. So the same data, everything that I told you, now one graph gives you this picture. So when you read a paper or when you analyze a paper, when you see a box and whisker plot, this must come in your mind. You understand that? That's the point I'm trying to tell you. That this should represent this in your brain when you see it. So here we have all the data, and this is how it gets represented in statistics. Okay. Did it make sense, guys? Hello?
Yes, sir.
Okay.
Yes, sir.
Good, good, good. Some of you may not understand it. It's okay. Go back and look at it again. Okay. This I'm unhappy because they've shown the second quartile. I would have been happier if they had shown the first quartile. So better to show the first quartile. Okay. All right. So much so about percentage, mean, and median. Let's look at mode. Okay. Let's see how mode is used. It is used when we need a label for the most frequently occurring event. Okay. So that's quite important. The most commonly occurring value is the mode in a study. Okay. Or it is the most common of a set of events. So many things are happening. The one which is happening the most is the mode. Okay. Different studies will look at different. So some will look at value, some will look at events, description of an events. Okay. So each one of them can. So if you look at Sachin Tendulkar scoring 100 runs, and if you look at the number of singles he's taken, the number of twos he's taken, the number of threes, number of fours, and number of sixes, then the mode will be whichever one was the most frequent. It could be 1 or it could be 4. We don't know that. It's not the strength of that variable that is important. It is how often it has happened. That is important. So 1 will be a mode, most common, because singles are more common. So he would have taken more singles than he would have hit 4s and 6s. You understand that? So the total of 1 will not be higher than 4s and 6s, but 1s is the mode in that conversation. So look at this graph, okay? So see this graph and try to identify in your mind when you see a graph, what is mode here, okay? So this is eye color of 100 consecutive patients. The mode here is brown. Okay? So mode may not be a number. That's what I'm trying to explain to you. Mode may not be a number. The mode may be an event or a quality. Okay? So the most frequently occurring variable, we use the word variable. The most frequently occurring variable is called as mode. Okay? The problem is sometimes in a study, you might have more than one mode. You might have a bimodal distribution. So in this graph, you can see there is one high and a second high. So this is called as bimodal distribution. Okay. And so this is 2 modes in one study. So this in statistics is called as bimodal distribution. So when you see this graph, if I give you this graph in the exam and say, tell me what is the mode, you have to say, this is a bimodal distribution of data. And there are 2 modes, 10 to 19 and 60 to 69. You understand that? Is this clear or no?
Yes, sir.
This is how you have to interpret in the exam. I'm trying to give you stuff to say in the exam, okay? So now we come to the next one. We're still on descriptive statistics. Standard deviation, okay? When is it used? Standard deviation is used for data which are normally distributed. Just as mean, for standard deviation, you need data which is normally distributed. Just switch off your phones, guys. Somebody is on and it's crackling in my ears. Please, everybody, don't do that because, see again, switch off your data here, guys. What is wrong? So not your, what am I saying, data? Switch off your phones, okay, microphone. Right. See, it is important for me to concentrate. This is not an easy topic to explain. I'm not a statistician. So, and I want to talk to you at your level as a surgeon to surgeon. So I need to concentrate, okay? So try not to put on your phones. Only switch it on when I ask you, is it okay? That's the only time, okay? All right. Standard deviation, when is it used? Standard deviation is used for data which are normally distributed, okay? to provide information how much the data vary, the word is vary, around their mean. Okay, very important. This concept is the key thing to a lot of studies. So it's a measure of spread of score away from means. It is used for data with normal distribution. So when I ask you this question in the exam, doctor, tell me what is standard deviation, I expect you to say this. It's a measure of spread of score away from means, and it is used for data with normal distribution. This is the definition of standard deviation. Okay, don't give me your own interpretation. Okay, standard deviation. Standard deviation can be +1, +2, +3, which means it starts in the center and goes away. A +1 standard deviation means 68.2% of the values are included in a +1 standard. So whenever you write mean is 2 ± 4 with 1 standard deviation, it means that 68.2% of your values lie within that standard deviation. If you do a +2 standard deviation, 95.4% of the population or 95.4% of the variables will lie within that standard deviation. And if I do a +3 standard deviation, 99.7% will lie within the standard deviation. I want you to please remember these three figures by heart. +1 is equal to 68.2, +2 is equal to 95.4, +3 is equal to 99.7. This is an MCQ question, okay? So please, these three numbers are standard, they do not change. 68.2, 95.4 and 99.7. Very often they will ask you an MCQ saying +2 standard deviation represents 93.6%, 94.7%, 95.4%, 96.7%. And if you haven't read this number, you will not be able to pick up the correct answer. It's very confusing when you're in an exam. So these three numbers have to be remembered by heart. How do you represent this number on a graph? This is what it means, okay? So this is a normal Gaussian curve, okay? A normal curve, standard distribution. This is the mean in the center, okay? And the standard deviation +1 is 68.2%. I think this is from a serum cholesterol level in population. So if you say mean of so-and-so +1 standard deviation, it means 68.2% of patient population were lying between 175 to 225. Did you understand how you interpret this data? So when you've got values, the cholesterol level of +1 means 68.2% of the patients had cholesterol between 175 and 225. A 95.4, if you put +2 standard deviations, then the statement will change. 95.4% of patients had cholesterol between 150 to 250. And then if you go beyond, then 100 to 300, 99.7. This is how you talk when you talk about standard deviation. Is this clear?
Yes, sir.
Yes.
Yes, sir.
Good.
Yeah.
Okay. Same thing in a different representation. This one written horizontally, this one written vertically. Okay, just the same thing. So this is, if you look on the curve upstairs, this is 1 standard deviation, this is 2 standard deviation, this is 3 standard deviation. It's the same thing for a different. So papers can present it in different ways. So you can work it out, okay? Depending on whatever is the paper. This is a graph of patients in a trial with a mean age of 80 kilograms. And standard deviation was 5 kg, okay? So this is how you say. So 80 was the mean. When they say standard deviation of 5, they're talking about +1 standard deviation. So the interpretation of this graph, when I give you this graph, I want you, if I say interpret this graph, you have to say 68.2% of patients were lying between 75 and 85 kilograms. That's the statement I want you to say. Okay, so that's how you answer statistics questions. Don't talk about these values. I want you to talk about this value on the x-axis, and I want you to tell me how many percentage of patients were between 75 and 85. 68.2. You understand? Both ways I can ask you the question. Okay, so if we have two sets of data with the same mean but different standard deviations, then the data with the larger standard deviation has a wider spread than the data with a smaller standard deviation. So this, I'll just come back to this. Look at this graph, keep this in mind, okay? If you had two separate sets of data with different standard deviation, so if you, instead of using 5, here they use +5, right? So if they used a +5, instead of that, they said +3, standard deviation of 3. Look at the shape of the graph that has changed. Can you see that? And so the value has changed. When the number of standard deviation has changed, +1 standard deviation now moves from 75 to 85. That was in 5 kilograms, but here it has moved to 77 to 83. So the graph will change depending upon what is the mean and what is the standard deviation value that you have added to your statistics. That is the point I'm trying to make, that the graph becomes narrower when the graph becomes wider when the value is higher of standard deviation. The graph becomes narrower when the value is lower. Did you understand this concept?
Yes, sir.
Okay, all right, thank you. Okay. Now, very often in a paper, you will be given some values, okay? And you need to check whether actually have they given sensible values or not. Is the standard deviation sensible or not? And the way to check in a paper whether the standard deviation is given is sensible or not is to first look for normal distribution and then look for two standard deviations. Okay. So if somebody has given you a value of standard deviation, calculate it into two standards. So 2 into that value, and then look if the mean falls between possible ranges or not. Example, okay. So length of hospital stay data, the mean was 10 days, and they said a standard deviation was 8 days. This is what the paper stated. Now, two standard deviations is mean minus 2 into standard deviation, which is 10 minus 2 into 8, okay, is minus 6 days. Minus 6 days is not a realistic number. It can never be minus 6 days. So it tells you that this distribution is not normal. It's a skewed distribution. It is not a normal bell-shaped curve. Hence, the use of standard deviation is not correct in this paper. Did you understand this concept or no?
Sir,
Yes, sir.
it once, please.
Mean to say standard deviation cannot be used in all data.
Yeah,
it has to
should
be used only in
in
normal data.
distribution. It
Uniform
has to be
distribution.
used in normal, uniform distribution. So if you want to check that a paper has the distribution in a particular patient is normally distributed, take the mean, take the standard deviation, and multiply it by 2 standard deviations and take it away from the mean. So mean minus 2 standard deviations. If the number that you get is sensible, then it is okay. But if -6 is not a sensible number, so this study has not represented the standard deviations properly. Hence, this distribution is not normal. This is probably a skewed distribution, and the author did not even understand it. Okay, this is how you check whether standard deviation is. So in the exam, just say mean minus 2 standard deviation, and if the value is sensible, then it's okay. If it is not sensible, then it's not a normal distribution. Okay. Made
Okay,
sense or no? I'm
Yes,
sorry.
sir. Yes,
Yes,
sir.
sir. Yes.
This is stuff
Yes, sir.
which are real life incidents which happen in papers. And if you don't know how to read it, you will say one paper is very good, and that's not what we want. Okay. Did it make sense? Mean minus 2 standard deviation will tell you whether the distribution is uniform or not. It's as simple as that. Okay. So far, so good. We've covered percentage, mean, median, mode, standard deviation. Did it make sense to everybody?
Yes, sir.
Yes, sir. Yes.
Yes, sir.
Yes, sir.
Okay.
Yes, sir.
Let's get into the next one. Okay.
Not
Let's
one
get
reference.
into. Yeah. Sorry. What was it, Vikas?
This does not mean that study was wrong. This means he used the wrong statistic to
That is
describe it, right?
That is correct. That's all. That is all it means. We are not saying study is wrong. We are saying his description is wrong. Okay. Let's look at confidence and p-values. Okay. All right. So confidence interval. When do you use a confidence interval? The confidence intervals are typically used when instead of simply wanting the mean of a sample, we want to know if this range represents a true population value. So whenever we do a study, say there are 1 million is the population of UK, and I want to study how many patients had COVID. So I will take a sample of 200. So when I take a sample of 200 and I calculate a mean value for that, the moment I put confidence intervals with the mean, so if I put a confidence interval of 95%, it means that I am 95% sure that the mean represents the whole population, the 1 million population. Did you understand what I just said?
Can you please repeat it?
1 second, sir.
Not
Keep going.
exactly.
Stay with me. Stay with me. Okay. So when a study says mean value of a sample, okay, this you've understood this word, mean value of a sample. Did you understand that? Okay. 20
Yes, sir.
is your n, and the mean value is whatever. It doesn't matter. But does that mean value apply to the whole population? A larger population outside of your study, there may be 1,000 cases. Your study is only 20 cases. So does your mean value, does the mean value of your sample truly represent the mean value of the population?
No, no.
That's the question. So when you add a confidence interval to the mean value, so when you say confidence interval 95%, it means out of the true population, I am 95% sure that the mean represents the whole population. Okay.
Yes.
Now
So if you don't understand.
Understood.
Okay, if
Understood.
you don't understand.
Understood.
Okay. Just stay there. So what is true value? Is if we have used a mean value for a sample, then what would we get value for the whole population? That is called as true value. Because really any study is done so that you can apply it to the whole population. The sample is not the real answer. The real answer is the whole population. So confidence intervals is a range of value within which you are fairly confident that the true population lies. So 95% confidence intervals means I am 95% confident that the population value lies between those two limits. And I'll show you a graph. Don't worry about it. Okay, let's look at the example. So look at blood pressure reduction with a hypertensive drug. Okay. The mean blood pressure reduction we got for the population study. If we took another sample, the mean may be different, right? Because other factors may change things. You agree or no? So confidence interval actually represents the true value if infinite patients are treated. So forget the third line, look at the second line and look at the fourth line. So confidence intervals represents the true value if infinite patients are treated. So something like this: 100 hypertensive patients, the mean systolic blood pressure is 170 millimeters of mercury. After treatment with drug, the mean blood pressure dropped by 20 millimeters of mercury. Okay. When we put a 95% confidence interval in the statistical package, it came up with a value of 15 to 25. So now we are 95% confident that in the general population, in study population, it dropped by 20 millimeters, but in the general population, the blood pressure will drop it by 15 to 25 millimeters. That is what is meant by a confidence interval. So higher the confidence interval, more accurate is the study. That is what we mean. Did you understand this or no? A lot of people will not understand it, and that's okay. You have to keep going back and reading it. Did this make sense? This slide makes sense or no?
Yes, sir.
Yes, understood.
Yes, sir.
Yes,
Yes,
sir.
sir.
And whoever has not understood, go back and keep listening to my talk again. Okay, that's the only way you will understand it. So size of the confidence interval is related to the size of the study. Larger the study, narrower the confidence interval. Because really you want a very narrow confidence interval to be more sure. 15 to 25 is a wide confidence interval because the study was less. The sample population was less. In a general population, if you can narrow it down to 18 to 22, then you have a more chance of success of the drug. So that's why you do a larger study. The larger the study you do, more narrow can you make the confidence interval. So this 15 to 25, if you did a, this is not it. Okay. The second and third line is by mistake. So this is the statement I want to make. The size of confidence interval is related to the size of the study. The larger the study, the confidence interval can be narrowed. Does that make sense?
Yes.
Which means more accurate is the study.
Yeah.
Yes, sir.
sir.
So the sample population more accurately represents the general population. Okay. That is why the the sample size is very important in a study. The quality of a study depends on the sample size. Okay. So let's go ahead. So let's look at meta-analysis. We spoke meta-analysis is a method of combining results from a number of independent studies, okay, to give one overall estimate of studies. I brought this here for a reason. So now this is how a meta-analysis is represented, okay? There is something called as a forest plot, yeah? Now, if you look at this forest plot, there are 5 studies, A, B, C, D, E. Are you with me so far? The meta-analysis
Yes, sir.
looked at all of this. So this vertical line that you see is the mean. Is it clear? Can you see my arrow?
Yes, sir. Yes, sir.
This horizontal line is the confidence interval of that study. Okay?
Yes,
This
sir.
was another study which looked at the same thing but got a wider confidence interval because probably their numbers were smaller. Okay, this study probably had a bigger number. So it is managed to bring this confidence interval to a more narrow margin. Okay. And when you do a meta-analysis, all of these 1, 2, 3, 4, 5 are put together into the statistical package and it comes out with a diamond. The midpoint of the diamond, this too, is the mean.
True mean.
True mean of that meta-analysis. And this is the confidence interval of that meta-analysis. So with this wide range, you have managed to squeeze down the confidence interval to a very narrow margin. Can you see that?
Yes.
That is how you use meta-analysis. Because each of these studies may have had small numbers, small numbers, small numbers, small numbers. But when you put all of them together into a meta-analysis, the number became larger. Hence, the confidence interval became narrower. Did this make sense?
Yes, sir.
Yeah, this is how you understand confidence intervals. Okay, so I will give you a real life example now. This is
What is this,
from
a
my,
globogram?
that's just the word, another word for forest plot. Okay, that's another word for forest plot. Some papers use it. This is my paper. Okay, this is from my paper. This is where we have looked at open versus multi-port VATs. Okay, we've looked at open versus multi-port VATs. I think this one is looking at number of events. Okay, something we were looking at, whether this is one of the forest plots from my paper. So I'm just showing you how we represent. So look at each study had multiple different confidence intervals and means. Okay, look at it. But by doing a meta-analysis, we were able to narrow it down to a really small number. And then if it is on one side, this is an odds ratio, okay? So this is not just simple. I haven't spoken about odds ratio as yet, but you can use the same concept, a forest plot using odds ratio. And in an odds ratio from 0 to 1, 0 to 100, 1 is in the midline. If this lies on the right, it favors multi-port VATs. If it lies on the left, it favors open surgery. So I don't want you to interpret this graph. I just want you to understand how a meta-analysis is used to form a diamond and how confidence intervals changes when you do a meta-analysis with a larger sample study. Does this make sense?
Yes.
Yes,
Yes.
sir.
Hmm.
No. Okay. All right. Don't worry.
Yes.
So some statistical packages actually, instead of giving you this, giving you numbers, categorical numbers, can actually change the confidence intervals to 0 to 1. Okay. -1 to 1. It can change that. And I'll show you what happens there. So if a confidence interval is tight, and the variation is small, then it is a good confidence interval. So in the first study that I showed you, this is terrible. What is this? This study B is a terrible study because what is this -40 to +10? It is rubbish. You agree or no?
Yes, sir.
So a good confidence interval is when the variation is small and tight. It is, if everything is on the same side of unity, means all the confidence intervals are on the same side, it is a good study. And then the statistical package, as I told you, can make it from 0 to 1. Okay, instead of giving you 15 to 25, the package has the ability to change that into unity. So it can give you the confidence intervals from 0 to 1. Are you with me? Don't worry about the
Yes, sir.
mathematics. Don't worry about the mathematics. Don't worry how it has become 15 to 25 to 0 to 1. It has just changed it. So -1 to +1. It has just changed the same representation. The package has given you a representation from -1 to +1 with 0 in the middle. So if the confidence interval goes beyond 1, then it is not statistically not significant. It'll come in a minute. Stay with me. If it is all on the same side of unity, it is statistically significant. If it is below 0.85, it is clinically significant. So these are the three numbers you have to remember. Beyond 1, same side of unity, less than 0.85. Now, same thing I'll bring up. Same studies, they have now tabulated, instead of each value of that, the computer has calculated ratios and given you a confidence interval of -1 to +1. Okay, so look at this, 0.88 to 1.12. This is touching beyond 1. This is not significant. If it lies between 0.88 and 1, this is statistically significant. If it touches 0.85, it is clinically significant. Does that make sense? This is touching 1, so statistically not significant, but clinically significant. And this is statistically significant and clinically not significant. This is a little complex because we haven't done odds and ratios yet. But I'm just showing you how the confidence intervals can be tabulated by computers. And just by looking at a graph, just by looking at a meta-analysis, you can say study A was statistically not significant. Study B was statistically significant, but clinically not significant. Study C was statistically significant and maybe clinically significant. Study D definitely was touching 1, so it was statistically not significant, but clinically significant. And study D is both statistically and clinically significant. I will put this up on the website. When we have done ratios, this will become more clearer. Okay, don't worry about it. I know you will not understand it at this moment, but when I do the ratios, odds ratios, and risk ratios, this graph will start to make sense. But just stay with these 3 factors. Touching 1, less than 0.85. That is what you have to worry about. Okay? Did it make sense? No.
That chart, in that chart, the critical, the CI is of RR, right?
Yes, it's an RR. That is a further tabulated. It'll come, don't worry, just stay with me. I had to use it here just to show you how confidence intervals is used in studies. Did you understand forest plot? Up to forest plot?
Yes, sir.
Yes.
If you understood up to here, I'm happy. Okay.
What is
If
that
you
vertical
understood,
line?
the vertical line is the ratio, is the odds ratio here. So in this, it is 0, but when you do odds ratio, the vertical line is unity. It's called as unity. Okay.
Is there a
It
significant?
falls on this. Wait, we have not yet come to this, so stay with me. Everybody will get confused otherwise. Okay. Stay with me. Are you okay?
Yes, sir.
Yes, sir.
Somewhat.
Sorry.
Okay.
Yeah, somewhat okay. Okay. I didn't expect you to be happy at the end of this presentation. But it takes time. You have to work on it. Okay.
So far, so good.
All right. So far, so good. At least you understood what is 95% confidence interval. 95% confidence interval means that I am 95% confident that the mean that came in the sample population represents the true value in the world. Okay. That is all you have to tell me.
Yes.
Yes.
Okay. All right. P-value. Can you come with P-value? Do you want to understand this? Okay. The P-value, the probability value, is used when we wish to see how likely it is that a hypothesis is true. Is this okay? Yes or no?
Yes, sir.
Yes, sir.
Yeah.
Yes, yes.
So the hypothesis is usually null's hypothesis. Whenever we start a study, we start with the null's hypothesis, that we say that there is no difference between the 2 treatment groups. Are you okay with this?
Yes, sir.
Okay. So we use the p-value to test a null's hypothesis. Okay. So the p-value gives a probability of any observed difference having happened by chance. So let's first talk about null's hypothesis. Null's hypothesis says that there is no difference between the groups being tested. Yeah, okay with this concept?
Okay, sir.
All right.
Yes, sir.
So the result of a test either supports or rejects the hypothesis. Is this okay?
Okay, sir.
Straightforward statement. Okay, nothing complex.
Yes.
Okay. Paradoxically, the null's hypothesis is usually the opposite of what we are actually interested in finding out. So if you want to say that if you want to say that smoking causes cancer, then the null's hypothesis says smoking does not cause cancer.
Yes,
Okay, that's how you start your study. All studies are started with a question, and the question is always null's hypothesis, because null's hypothesis is exactly opposite of what you're trying to prove. If you want to know that there is a difference between 2 treatments, then the null's hypothesis would be that there is no difference. Okay, that's the same line, I'm saying it again. The statistical test that you use, you actually want to disprove your null's hypothesis. Does that make sense? I've
Yes, sir.
repeated it a few times because I want you to understand this. So there is two types of errors which you have to know. There's a type 2 error and a type 1 error. Just stay with these two slides and we will not talk about it more. We will come back to it a bit later. So a type 2 error is when there was a difference and your study failed to detect the difference. Okay? Does that make sense? So it's a wrong
Yes, sir.
study.
Yes.
It's a wrong study. There was actually a difference. Null's hypothesis said that there was no difference. Your study, the statistical test that you said, showed there was no difference. But actually there was a difference. So that's a type 2 error. In an exam, they will be asked. So type 2 error of statistics is when a study fails, when a statistic fails to detect a difference, when actually a difference exists. False negative. Okay. Did you understand that? It's a false negative.
Yes, sir.
Yes, sir.
Yeah? Okay. Type 1 error in a null's hypothesis is that you detect a difference when there was no difference. Made sense or no?
Yes, sir. False
Yes, sir.
positive.
Yeah, false positive and false negative. This is type 1 and this is an error. This is not the part of the study. So what does the p-value does is p-value gives you the chance of saying whether this happened by chance. So if a p-value is not 0.5, okay, if you did a study and the p-value p-value came as 0.5, then the difference that you saw between the studies happened by chance. There was a 50% chance that it was one and a 50% chance it was other. So not very good, right? 50-50 is not very good. Agreed or no?
Yes, sir.
Yes, sir.
If the difference comes down to 1 in 20, p of 0.05, then this is the value. This is not by chance. This is genuine. Okay. So this is not by mistake or not by chance. This is genuine. And that is why p value of less than 0.05 is called as statistically significant.
Significant.
Did you understand this concept or no?
Yes, sir.
If you go even lower, then
More significant.
chances are going down. So the significance is going up. The moment the p value is going down, the significance is going up.
Yes.
Yeah? Can you see that?
Yes.
1 in 20, 1 in 100, 1 in 1000. So the chance of it being by mistake is gone down. Did you understand this concept? It's very important to understand the concepts. So what do you mean by that, statistically speaking? P less than 0.05 is statistically significant. P less than 0.01 is highly significant. And P less than 0.001 is very highly significant. Did I make myself clear or no?
Yes, sir.
Yes, sir.
Yeah? Okay. So statistical versus clinical significance is different. Okay, statistically it may be significant, but it does not mean that clinically it will be significant. You understand that? You can fudge statistics and get a clinic. You can fudge the numbers, but really does it represent in true life or not in your clinical practice? So always understand that a P less than 0.005 doesn't mean that it is clinical significance. And that is why the confidence interval is then divided into touching 1, touching 0.85. Did you understand that previous graph that I showed you? Hello?
Yes, sir.
Yes, sir.
I showed you a
Yes,
graph
sir.
where the
Yes,
confidence
yes.
interval was touching 1,
Yes.
something was touching 0.85.
Hmm.
Just the
Hmm.
p value again cannot tell you whether it's clinically significant or not. P value only tells you that it is statistically significant. So that is why you need to put in confidence intervals to add meaning to your statement that you're making. A drug may work, but statistical significance may not be found if the study sample is small. So p-value is completely dependent on the sample size. It's really very important to understand this. Conversely, a large study you may have a large study and you might find a statistical significance, but it will be too small for clinical relevance. So this is what happens in real life. That don't get hooked on to p-values. That is what I'm trying to tell you. Don't get hooked on to p-values. What you need, we spoke about the quality of evidence. What you really need is a statistical significance that has clinical impact. You understood this or no, this concept?
Yes, sir.
Yes, yes.
You have to stay with me. It's not easy, but you have to stay with me.
Understood.
Okay. So this is a one which says, yeah, this is p-value, just to show you how p-values are calculated, okay? So 0.05, 0.01. So this is how a study does that. Okay, so far so good. Forget that. I think confidence intervals threw you
Yes,
a little bit.
Yes.
But did you understand p-value? Simple.
Yeah.
Yes, sir.
Yes, sir. Yes, sir.
All right. Now it cannot be simpler than this. I'm really trying my best to bring it down to grassroots levels. So that is about confidence, and that is about p-values. Now let's look at how to test differences, okay? What are the tests? There are parametric tests and non-parametric tests, okay? And chi-square test, which is a parametric test, okay? So when do you use a parametric test? Parametric tests are used when the data is normally distributed. Very important. So if you want to compare group A versus group B, the distribution has to be normal. Only then can you use parametric test. If the distribution is skewed in any of that group, you cannot use a parametric test. So if it does not follow a normal distribution, these tests cannot be used. Did this statement make sense? Simple. Okay.
Yes.
Okay. This is a fact. I can't change this. This is a fact. So they are used to compare samples of normally distributed data. Normal distribution. That is the key thing. So whenever you talk about parametric tests, you have to say we are using normal distribution. So what are the three tests that are available? Student t-test, ANOVA, and chi-square. Okay. Okay. Now there is another test available. This is all. You don't have to know the mathematics of these tests. You just don't have to. All you need to know is these tests are used by the software to give you a p-value. That's all. It's as simple as that. Now, sometimes if you have a data and you don't know if it is parametric or not, if it is uniformly distributed or not uniformly distributed, then you have this test available on the software, which will actually tell you, by using this test, you can decide whether the data is normal distribution, and it tells you whether the parametric statistics can be used to assess this data or not. Okay, so I'm just throwing this name in case somebody, in some papers you come across this name, Kolmogorov, Smirnov test. This is, you don't need to know anything about this test. You only need to know that this is used before using parametric tests to know if the data has normal distribution or not. So when you enter this data into a software, you have to tell the software, now I want to do parametric test. I want you to do student t-test. If that data, you didn't realize that the data was not normally distributed and you put it in, the student t-test will give you a wrong answer because it cannot calculate. If it is a non-uniform distribution, it cannot calculate. So you use Kolmogorov-Smirnov test before to know that should you use student t-test or not. You understood that?
Yes, sir.
Okay, it's a little difficult, but please stay with me. Okay. Sometimes in statistics, when you put it on a computer, if the data is not uniformly distributed, you can actually convert the data into uniform distribution by using log of the value. So, 2, 4, 6, if you use 2, 4, 6 may not be uniformly distributed, but log 2, log 4, log 6 may become uniformly distributed. And this is a technique which is allowed in statistics to convert skewed data by using log of the values so that you can use parametric tests, because parametric tests give you very good results. And that's why you want to try and use parametric tests as far as possible. Did you understand? So this is a technique. So in the exam, somebody may ask you, but if you've got a skewed data, how will I use parametric tests? Then you have to say, you have to use log of the values. Now, I'm not teaching mathematics here. I'm teaching just concepts. So this is just a concept. Take it with me, take it from me, and just don't worry about it. But just remember that some papers actually have skewed distribution. So they use log of the values of the data and make it into a normal distribution and then apply parametric tests. And this is allowed in statistics. Okay. All right. Okay. I'm just making a statement there. So let's look at the student t-test. It's a parametric test used to compare the means of two groups. Is the difference valid? If the mean of group A was 2 and the mean of group B was 4, are these two means different from each other, okay, in treatment? That is what you're trying to do. So do not look at the t-statistic value of the test. It comes up with a student t value. You have to look only at the p-value of this test, nothing else. Don't worry what comes out of that software. Just look at the p-value, and the p-value will tell you less than 0.05, significant or not significant. Okay, does that make sense what I just said? So this is the same thing that I've said. We did this test for these two groups. One group had peak flow meters of, the mean was 96. The placebo group had mean of 70, okay? The null's hypothesis was there is no difference between the bronchodilator and the placebo group, okay? So we don't know if this and this are different. Is there really a difference between treatment group and between placebo group? So what we did is we put these two figures on the computer with a parametric test. The parametric test came back, the student t-test came back saying the t-statistic is 11.14 and the p-value was 0.01. This is the answer you will get from a test when you do it on the computer. The SPSS will throw back these two values at you. All you have to look at is this value. The moment you have this value, it says that very unlikely that the null hypothesis is correct. So we reject the null's hypothesis and conclude that the new bronchodilator is significantly better than the placebo. This is a very important slide. I hope you understand this example.
Yes,
Yes
sir.
or no?
Yes, sir.
Yes, sir.
Yeah, this is the key of understanding how you use statistics. So the first half is descriptive statistics. The first half is you're using means of the whole group. There is study of whatever number of patients. You've found out the mean of A, you found out the mean of B. But really, does A and B, how do you compare A to B? Then you use parametric test and you come out with a p-value. And once you get a p-value, that is when you say whether the null's hypothesis is correct or you reject the null's hypothesis and say A is better than B. Did you understand that?
Yes, sir.
So using bronchodilator is significantly better than using nothing in asthma. Yeah?
Then placebo.
Made sense or no?
Yes, sir.
God, we are already 2 hours into it. Oh, shit. Okay, ANOVA, analysis of variance, is another this thing, but another test, parametric test, but here we use means of two samples, 2 or more samples. So sometimes you might have 3, 4, 5 groups. So how do you compare the mean of all of those groups? So you use analysis of variance, okay, of the same population. So when you have many independent variables, 2, 3, 4, 5, 6, then you use analysis of variance. When you have only 2 samples, you can use t-test. ANCOVA is when it's an extension of analysis of variance. There is something called as independent variables and continuous variables. Don't go too much into this. Just understand there is something called as ANOVA and ANCOVA. Both of these are used when there are more than 2 samples. Okay. So here we are. So we've got, look at ANOVA. Don't look at the first, just look at ANOVA. So in an ANOVA, if you have 2 to 9 groups that you have to compare, okay, then you can use ANOVA. When you have more than 2 groups, you can use ANOVA. Yeah. So these are various tricks of the statistic. You don't need to know these details. Just that this is how you use these 2 tests. Did it make sense or no, guys? I know
Yes.
I'm going
Yes,
very
yes,
slow.
yes.
Yes,
But
sir, yes.
Yes,
it is
yes.
important that
Yes.
you understand.
The last slide was a little confusing.
No.
This one, forget this. Don't remember that. Okay. All right. Look at chi-square test, another parametric test. Okay.
Parametric
This
test or
is
non.
this is a test of association between 2 categorical variables. Okay. It measures the difference between actual and expected frequencies. That's the definition of a chi-square test. So the expected frequency is that there is no difference between the set of results. Okay, that's the null hypothesis. In this case, the chi-square value will be 0. The larger the difference between the set of results, the greater the chi-square value. But it is very difficult to interpret chi-square. So again, I'm telling you, when you do a chi-square test, only look at p-value. Full stop. Don't worry about it. Only look at p-value. Okay? Is that clear? Simple. I don't want to go into too much details about each one.
Yes, sir.
Just look at p-value. Simple. Okay? Okay. When you have a very small sample size, when the sample size is very small, then you use a Fisher's exact test. Okay? It is very good to give you an exact value of P when the numbers are small. Simple. So when you've got 5 patients, 4 patients, 10 patients in your sample group, don't use a student t-test, use a Fisher's exact test. Okay? I'm just telling you where it is applied. Forget everything. Just when the numbers are small, you use a Fisher's exact test. These are another couple of more tests that you use. Mantel-Hansel's test is used in meta-analysis. So I'll just put it here for completion. Okay? That they are an extension of chi-square test to compare more than 1 two-way tables. And these are used in meta-analysis. You don't need to know it, but just know these are parametric tests. Okay? Is it clear so far or no?
Yes, sir.
Okay.
Yes. Yeah.
Now, non-parametric tests are used when the data are not normally distributed. Simple. So are not appropriate for parametric tests. Okay. So when the data is not normally distributed and not appropriate, or when the data is skewed, you can use non-parametric tests. The non-parametric tests compare the value. See, rather than comparing the value of the raw data, there is a technique by which you can rank the data. And so the data is converted to ranks, and then the ranks are compared. So instead of using raw value of the data, this is just the technique of how the test is done. You don't need to know it. The statistician will do it for you. When you are doing it on SPSS, we convert raw data into ranked data. And then you compare the ranks and then you get a mean. Okay. So this is a skewed data completely. It's up and down all over the place. So what happens is it's a better study for medians. Okay. It's a better study for small sample size and better study for ranked data. Okay. And when you've got a lot of outliers, so when you've got skewed data, you usually use non-parametric tests. Simple. So what are the non-parametric tests that are available? Mann-Whitney test, Wilcoxon-Sign rank test, Cruxall-Wallace test, and Friedman's test. Okay. These are just the names. Anytime anybody puts up this name, say this is a non-parametric test. And out of these tests, what you will get is a p-value. Okay. So a non-parametric test that tests the difference between 2 sets of data that have come from 2 different set of subjects. But you get something called as a U value out of the Mann-Whitney U test, but don't look at the V value, look at the P value. That's it. It's very simple. Okay. Forget about all this. If you want to know about each test, I put it up there, what it means. These are paired tests, paired groups. Okay. So it compares the difference. What you're doing is comparing difference between two paired groups. You can use a Wilcoxon rank test. You don't have to decide. The statistician will decide this for you. Okay. But what you have to look at is P value. Okay. Again, just I've put this up there for you to understand what the test means. So the first one was for paired values. This is for independent groups, 2 or more independent groups. It's difficult, but I'm trying my best to explain it in simple language. So far we've done percentage, we've done mean, we've done median, we've done mode, we've done statistical difference. Okay. We then did confidence intervals, and then we did P value. 6 things you understood?
Yes, yes.
I hope so.
Yes.
The remaining test, what we did was parametric and non-parametric test. The parametric test can be done only for uniform data. The non-parametric test is done for skewed data. All you have to look at is the P value. The parametric tests that are available to you are the following: t-test,
Chi-square.
yeah, chi-square test, and Fisher's exact test. Okay. Yeah. The non-parametric tests that are available to you are Mann-Whitney U, Cruxall-Wallis, and what else I forgot? Wilcoxon signed rank test and Friedman's test. Is it clear now? This is all I want you to remember.
Yes, sir. Yes.
Can you remember these facts?
Yes.
Yes,
Yes.
sir.
Okay, that's all I want you to remember. Okay.
Discuss in next class, sir.
Discuss in next class. Okay, all right. I'm happy to start.
No.
No, what they meant to say is you check whether we understood or not in next class.
I think this will go. This will go over 3 classes. I think I'm really concerned.
It seems yes, 3 classes would be better, right?
Okay, so we are 2 hours, and we have. But the first half that you've understood is the most important half. Okay, is the most important half of statistics. 95% of statistics works in the first half. The 3 types that I told you.
Yes.
Did it make sense?
Yes, sir.
Yes,
Yes,
sir.
sir.
Yes, sir.
Okay,
Yes.
I spent so much time to explain very basic things.
Yes, sir. This is only important in exam. They ask some data is given, and they will ask you the test of which you will apply for this scenario.
I have got the data. I've got scenarios for you guys. So I have got scenarios, and I'm going to go through each one of them. Unfortunately, when we are doing it online, it's very difficult to try